So
Cool.
just to introduce everybody, this is Bill Woodhams. He's one of our Michigan State medical students. He's going to be giving us a talk on subtrochanteric femur fractures, and this has been, Bill has waited patiently for about a month for me to be available to host this, so glad to have everyone here. And let's get started. Really quick as a reminder, we record these kind of talks, what we call grand rounds, for our ortho conditioning platform. You can find it on Spotify, actually, and surprisingly Spotify allows video, which is cool, and you can also find it on our YouTube channel, which we've been kind of experimenting with, so it's pretty cool. So go ahead, Bill, take it away.
All right. Well, first, thank you everyone for coming and listening to my talk on subtrochanteric femur fractures. Like Drew said, I'm a second-year med student here at CHM. Just start off, I don't have any conflicts of interest, nothing of that sort. The objectives of this talk, we're going to go over the anatomy of the subtrochanteric femur, the background of these types of fractures. We're going to look at identifying them, classifying them, and then how we would treat it, as well as then a really good journal article that we found that helps illustrate all of these ideas. So to start, for the anatomy, the subtrochanteric region of the femur is defined as the metadiaphyseal proximal femur within about 5 centimeters distal to the lesser trochanter. So that's a very specific region, so that's what defines a subtrochanteric femur fracture. It also involves the femoral calcar, which is a posterior medial bone, which helps provide a lot of structural integrity to that region. And that's something that can be involved in these fractures and cause a lot of instability and problems. And a lot of the muscle groups that attach to the subtrochanteric region, or at least impose forces, are like the hip abductors, the adductors, the short external rotators, and the iliopsoas. So for a background on the subtrochanteric femur fractures, it's about 10 to 34% of all hip fractures, depending on the source you look at, but it's a significant amount. And most of them do occur in your older population. Patients over 51 make up about 2/3 of them. If you're going to get a subtroch femur fracture in a younger patient, it's going to be a higher energy mechanism. So you're going to think of things like car crashes or falls from really high heights, that type of deal. For older individuals, it tends to be a lower energy mechanism. It could be a fall just to the ground from standing height even, or a bisphosphonate associated fracture as well. Bisphosphonates, as you know, can increase the risk of certain types of fractures. And these types of fractures tend to have, if they're go untreated or they're not treated properly, they can go on to have non-union, malunion, or and really poor clinical outcomes if they're left untreated. So a lot of the deforming forces that you look at in these types of fractures is that the proximal fragment becomes abducted by the gluteus medius and minimus, while it's being flexed by the iliopsoas and externally rotated by the short external rotators. And that helps break that bone in that subtrochanteric region. Whereas the distal fragment is adducted and shortened by the adductors and the gracilis. So when you're diagnosing these type of fractures, you want to think about the mechanism of injury, what types of deforming forces were going through that bone. That might lead you more towards a subtrochanteric femur fracture.
Yep, this is probably, just to interject really quick, this is probably one of the most important takeaways for subtrochs is this deforming force. So it's a big differentiator between intertrochs and subtrochs, because some intertrochs, like we talked about a few weeks ago, they can extend into the subtroch region, but they won't look like a typical subtroch, which has this very specific pattern where the proximal fragment flexes up, abducts, and then externally rotates. So when you look in a lateral, which we'll talk about, you can see the spike from the proximal piece really flexing up, and that's from your iliopsoas attachment to the lesser troch. So really, really important for identifying these types of fractures as well as fixing them too. So cool.
And for identifying these types of fractures, again, you're looking at the mechanism, the age of the patient, all of the things that you normally would in a patient encounter, along with any associated injuries or premorbid diseases. But on the physical, you're going to tend to see the shortening of the extremity, along with deformity of rotation compared to the contralateral extremity. You're going to see a vallus disalignment or malalignment, and then pain or crepitus with motion of the hip. It's going to be quite painful. They broke their femur. And then a lot of swelling and discoloration with an associated hematoma is very typical of a subtroch femur fracture. And then the next thing you're going to do, you're going to get an x-ray. So on plain radiographs, you're going to get your AP view of the pelvis. You're going to get an AP and a cross-table lateral view of the affected hip, and an AP and lateral radiograph of the affected femur to the knee. That's very important because if you're going to be operating on the femur, you need to have a full radiographic view of the entire bone that you're operating on. So that's crucial. Don't just get the radiographs of the hip, do the entire femur. Along with, you're going to avoid the frog leg lateral views. This is mostly due to pain. It's going to cause excruciating pain if you do that. And so over here on the right, you can see we have an AP radiograph demonstrating a comminuted subtrochanteric femur fracture with a shaft extension. And then that proximal fragment is abducted, externally rotated, and flexed. So that's what you're going to be looking for on a plain radiograph to diagnose a subtroch.
And that's kind of like a really bad one. That's not typical to have comminution all the way up into the what looks like basocervical region. That's just like really looks like a bad one. So usually in typical subtrochs, the inner troch region as well as femoral neck region isn't fractured as well. So that's a kind of extreme example.
And so once you know that it is a subtrochanteric femur fracture, you're then go on to classifying it. And so I have a couple slides here really demonstrating the different classification of these fractures. And this is a Russell-Taylor classification. So you're going to start off with a type 1, and that's divided down into a type 1A and a type 1B. So the type 1A, you're not going to have any extension into the lesser trochanter, whereas in the type 1B, it will extend into that lesser trochanter, as you can see in the upper right-hand image. But then you're going to have a type 2 fracture as well, which will, the type 2A is not going to involve any comminution of that lesser trochanter, but it will extend into the piriformis fossa. But the type 2B becomes even worse because you get a comminution of the lesser trochanter with extension into the piriformis fossa. And on this next slide, I think this one does a really good job of illustrating it. So on the left, you have that type 1A, so you don't have any comminution, you're not getting into the piriformis fossa. And then type 1B, you're getting the comminution in the lesser trochanter. Type 2A, it's getting up into the piriformis fossa. And then the type 2B, it's it's fracturing all up into the piriformis fossa and comminuting down at the lesser trochanter.
So this classification system, at least in our kind of hospital area, is not commonly used. And I think it's mainly because from reading a little bit more about this, it sounds like the classification was used to differentiate whether we should be doing a nail versus like a lateral plate or like a blade plate. And that was a more historical kind of differentiator. Whereas the new designs for nails make it possible to just kind of use nails interchangeably to treat kind of both type 1 and type 2 fractures, whether they extend into the piriformis fossa or not. So very, very uncommon to use blade plates for subtrochs these days. So it's a good classification to know of, but and someone correct me if they're residency or you've heard it in med school, use the Russell-Taylor classification, but we commonly don't use it.
Good to know. And we're going to look at the lateral plate fixation methods later on and some of the complications that can occur.
Nice.
And why they shifted over to the intramedullary nails.
Nice.
All right. So for non-operative management of these fractures, it's very rarely indicated. They're quite severe fractures. They don't heal well if they're not fixed. And a certain indication, maybe if a patient is in severe condition where it would be nearly impossible to operate and they're in end-of-life care, they're in palliative care. The goal is really just to keep them comfortable and they sustain this fracture. You may not operate then, but for the most part, most patients will do significantly better if you operate and fix the fracture. All right, so now into operative management. So the gold standard, you're doing an intramedullary locked nail. It's going to provide increased rigidity. You're going to have shorter movement of the arm. You're going to have a little bit of bending stiffness, but it's going to have a more efficient shared load transfer, which will help reduce malunions and non-unions, in the healing process. It's also going to help resist the deforming forces from the adductor muscles, and that's really important in keeping the fracture reduced as well. It's going to require. Go ahead.
Oh, sorry. You finish your thought there. Sorry.
I was just going to say, it does require a longer femur nail because the shorter nails fail due to instability and weakness.
Yep. So the difference between, if you picture putting a plate on the lateral femur and trying to control a fracture in a subtroch region that, even when it extends more proximally, your lever arm for where the forces are translating to that plate are actually longer for, like, even if you're using the center of the hip as the marker. So plating on the lateral femur with the center of your hip, you have this much lever arm here with gravity and the weight of your body, versus if you use a nail, it's going in the femur, which is more medial, and your moment arm for how much weight and force is going through that construct is less because of the lever arm is less. So that's what that means, shorter moment arm for nails.
That makes sense. Thank you.
Yeah.
All right. So the intramedullary locked nail, you're using this in your eligibility patients. It's a cephalomedullary intramedullary locked nail, utilizing a single lag screw. There you can see your subtrochanteric femur fracture, pre and post-op. It has been effectively reduced. The nail is intramedullary and it should heal up well. So that is your gold standard treatment option.
Nice.
So for younger patients, you're still very often going to use that intramedullary locked nail. You may opt to do like a smaller bore reconstruction with those type of screws because they offer a little bit less bone loss and a little bit more rotational control with the 2 points of fixation. So as you can see in image C, there's your subtroch fracture. It's quite severe. Post-op in image D, you have your intramedullary nail with two screws in there holding it and 2 points of fixation, which provides a little bit additional support.
This type of nail that is in that image is called a recon nail. So when you see that with 2 screws, most people would call that a recon nail. So the benefit is with the smaller screws that are spaced, like you said, rotational control, as well as your screw is taking up less bone stock in the femoral head. Mm-hmm. So that's why it's theoretically maybe better for younger patients versus one large cephalomedullary screw that just has a wider diameter and kind of takes more bone.
And is that better in the long run because they're a younger patient? Is that just why?
I think that's the theory behind it. I think a lot of surgeons, even in younger people, would still do cephalomedullary screws, or like cephalomedullary nail, where they have that one screw, whether it's a helical blade or a screw that goes into the femoral head. Pretty common to use that still, but recon nails have, I think, a good track record and the benefits that we just discussed. So
complications. So complications can definitely occur with these type of fractures. So on the left, you can see a non-union from the intramedullary nail in image A. It did not heal properly. It was not reduced entirely. And that patient is going to need further surgical operative management. Image B, again, there's non-union in that subtroch region. It is possible that the vascular supply to that region was compromised. So even though it is fixed with an intramedullary nail and it's stable from that perspective. The bone stock actually never healed back because it didn't have a proper vascular supply. So that's something that's very important in treating these types of fractures. In images C, you can see that the wire broke and you have a periprosthetic fracture there. In image D, again, another periprosthetic fracture with non-union. It did not hold up and heal properly. And there's your lateral plate in image D. And that is a common complication that can occur. And as Drew said, they're not widely used anymore.
Yep. Some people, blade plates can actually be good kind of rescue options in certain scenarios, but it's commonly not a first option for a subtroch fracture that I've seen anyways. The image in C, those are cerclage wires. But describing this fracture, I'd say this is like hardware failure, and you could call this a peri-implant fracture. It looks like they might have fallen and broken through their previous fracture. Periprosthetic, usually people would call that like a fracture around a arthroplasty implant, like a total hip or a total knee. So some people are sticklers about using the term peri-implant versus periprosthetic. Just fun fact. Good to know. Nice.
Didn't know that. All right, and then we have a journal discussion as well. So this is a full journal on treating subtrochanteric femoral fractures. So please ask questions, and so get a little bit of community engagement in this one. So in the image on the left, how would you describe that? What's the Russell-Taylor classification?
Before jumping to classification, does someone want to take a stab at describing just what they're seeing?
Yeah, I can try. So I see a AP and a lateral of a left femur. I see a fracture involving the subtrochanteric region of the left femur. It looks like there might also be extension into the lesser trochanter.
Nice.
Excellent. Nailed it. Excellent job.
Nailed it.
Nailed it. And then for the classification, maybe 1B.
Yeah, I think it's right on the border of 1A and 1B. They ended up calling it in this specific journal 1A, but again, it's very close. I agree with you.
Go back to your classification slide one more time. Go back one more. I would have said that I didn't see a fracture line going to the lesser, but for, med students that are hitting their away rotations and that type of thing, or for PAs calling attendings, usually you would just describe the fracture as you see it, and I wouldn't jump to the Russell-Taylor classification. That's just my opinion. So when we're staffing these types of consults, I've never heard an attending ask for the Russell-Taylor. It's just a good thing to know from in case someone asks you type of thing, but I would stick with left subtroch femur fracture. And that's all you need to say. So right when you hop on the phone, you can say, we have a patient with a left subtroch femur fracture. Boom, done.
Done. Keep it simple.
Yep.
I like it.
But I do think that makes sense with the classification there. Looking at that, go back to the x-ray one more time. I don't see a big fracture fragment or line going right into the lesser. It's kind of going out laterally. But as we talked about before, kind of the deforming forces here with the adductors or adductors pulling the femoral shaft medial, and then it's kind of hard to see on this lateral, but it's wanting to flex that piece up and externally rotate it. And how do you tell it's externally rotated? You can actually see more of your lesser trochanter in this case, and also the hip looks more valgus. That's a little bit difficult thing to explain without kind of like drawing it out, but if you ever get a chance to kind of hold a model, I think I might have one actually, but you'll notice when people externally rotate, it brings the more posterior structures forward, and the lesser trochanter is actually more posterior on the femur. So when you externally rotate that fragment, or when the short external rotators are rotating that fragment, you see more of the lesser. Does anyone know what the short external rotators are? What muscles? Whoa, someone's raising their hand. Let's see.
I had my hand up for the last one, but I think I'll give it a go. So you have your piriformis, superior gemellus, inferior gemellus, obturator internus, and quadratus femoris.
Exactly.
And then, yeah.
And the order, I believe, is piriformis, superior gemellus, and then obturator internus, inferior gemellus, and then quadratus femoris. But your gemelli and obturator internus are kind of a conjoint tendon, so they kind of run together. But that's a very common pimp question. I remember when I was a med student rotating with this joints guy, and he's like, what are the short external rotators? I'm like, I don't know. I'll have to look it up. So you guys are going to be ahead of the game.
We'll be prepared.
Yep.
All right. Does anyone want to give reading this radiograph a shot? This is the same patient, just postoperative.
Yeah, so it looks like they fixed it with a cephalomedullary nail. Looks like a piriformis start point.
Nice pickup.
I don't think it's a recon because it looks pretty hefty.
Yeah, I'm not familiar with this implant design, at least for what I'm used to seeing. But good pickup on the piriformis start point. This, I would not call this a recon nail because it doesn't have your kind of typical recon screw. It's kind of one cephalomedullary implant. This doesn't look like it is a screw. It looks like almost like a similar to a helical blade, but it's not helical. So I'm not going to talk about it anymore because I can't give you more details about what it is. But what do you think of, what other things do you want to evaluate, Noah, when you're looking at these types of constructs to see if they did a good job?
I would say alignment. It looks like it might be like slightly varus.
I agree with that. It might be slightly varus. What else?
Tip to apex distance. Or, sorry, yeah, that.
Yep, exactly.
So within 25 millimeters.
And, 25 millimeters in both the AP and lateral. So tip to apex distance is measuring the tip of your screw or implant that goes up into the femoral head, and measuring to that tip to the center of the femoral head on both those views and summing them together. Now, there's a formula that takes into account the kind of, what do you call it, scale of the radiograph, because depending on where your receiver is, that's receiving the image. So if your receiver is close versus far away, your image will be large or small, and it will affect your measurement. But a good rule of thumb, people aren't making the scale conversions while they're looking at these in the operating room or even in clinic. They're just looking at this and saying they can measure in their software to see what that total distance is in both the AP and lateral. And if it's under 25 millimeters, that means you did good, kid. So
have you seen because it looks like on the lateral view there's still some I guess comminution there. Would you I guess when do you consider using like cerclage wiring?
I would say, I think a lot of trauma guys, at least trauma guys and gals that we work with, don't like cerclage wires. I think a lot of joint arthroplasty surgeons like cerclage wires and using them to hold fracture pieces to their arthroplasties, like a femoral stem. So even with subtrochs, I have not seen people in our trauma world, in my experience, jump to cerclage wires. How about you guys on your away rotations? Have you seen the trauma faculty jumping to cerclage in any of their femur fractures?
I think, like you said, I've seen some arthroplasty guys using it for like a periprosthetic, but that's pretty much it.
I would say that's the most common scenario that I think people use cerclage wires. And I think that in fixing fractures from a kind of AO principle standpoint, you're thinking all the time, like, how can I get this fracture reduced and then stabilized in the most soft tissue friendly way? And I think people think of cerclage wires as not being soft tissue friendly because you're circumferentially wrapping very vascular structure, which is bone. So I think some people don't like that. So what do you think about the lateral? Is this more anterior or posterior in the femoral head?
Anterior.
That's what I thought initially, but I think it's a little bit confusing looking at the x-ray. It's more posterior just based on where the lesser is. So your lesser is a good kind of marker of which way is posterior, which way is anterior. Does that?
Okay. Yeah, I see what you're saying now.
Yeah, it's just not the way we're used to seeing it, I think, in the kind of software imaging systems we use. But any questions from any of that discussion? That's kind of a lot of information, but I guess people can see my screen. I'm going to draw this out. So I guess people will be able to see the screen on the recording, but not live. But I'm pointing to the tip of this kind of screw that goes in the femoral head, which is not a screw. It's more of like a blade implant. But from this point to the center of the femoral head, you'd measure that amount in millimeters and then add it to this point to the center of the femoral head here. So that's your tip to apex distance. That's also very commonly asked questions. And it's actually based off of literature for sliding hip screws, not nails or femoral nails, but people have kind of extrapolated it. Nice. Anything you wanted to add, Bill?
No, I think you guys did a great job covering it. Thank you.
Yeah.
I have a question.
Yeah.
What would you do at the bedside when you've come in to see a patient in emergency? So obviously stabilize the patient, ABCs, and then for the extremity analgesia, but then for the extremity stabilization, do you consider traction often?
I think we put skeletal traction in almost all of our femoral shaft patients. I would say for a smaller percentage of subtrochs, but some of the really comminuted, very flexed or very deformed subtrochs or even intertrochs, we will sometimes do distal femoral skeletal traction. So in this case, or this, if you go back a slide, might consider it for this, but I think it would be a tending preference based on whether they wanted skeletal traction or not. But I would say for most intertrachs and then even some subtrachs, we don't do skeletal traction for. And it's just purely based off of whatever institution you're working in, what people's preferences are. And the scenario really matters too, because if you have a polytrauma patient and they have a really bad TBI, or they're maybe intubated, you don't know when they're going to be able to go to surgery, then you have to consider, like, hey, maybe I should be putting this person in skeletal traction because we don't even know if we're going to be able to do surgery within a reasonable amount of time based on their status. So there's a lot of factors involved in regards to what is injured, what kind of state are they in, what was their functionality beforehand. For some reason in TBI patients, they have really robust bone responses. So if they end up being in the ICU for long periods of time, not being able to get surgery for whatever reason, then sometimes you wish you would have put them in skeletal traction, because they just form so much bone that it's kind of like the concept of every time you interact with a patient or you do a procedure, you want to make sure you set them up the best you can for the fact that you might not ever be able to work with them again. So you have to treat every single interaction like this is going to be the last time I'm able to work kind of on or with this patient. Does that make sense? Kind of rambled there a bit.
Yeah, I would just assess patient by patient.
Yep. And so generally for our hip fractures, subtrachs, you would obviously do your trauma exam, make sure everything's teed up from a like other team standpoint. And then you'd make sure you have all the information you need as far as finding every single like ortho injury that you need to cover and be responsible for. And then kind of from there, prioritize and execute what you need to get done in the ED. Like we talked about, skeletal traction or not. Where else was I going with this? It doesn't really make sense to splint femurs, just because they're so high. Like in this case, a splint would not really be helpful for you. And then you want to do your best to make sure they're teed up for surgery. So that means not relying on other teams to get the labs you need, like what is their CBC, what is their lactate. A lot of trauma teams do that automatically, but the one time that you want that value or whatever it is, like a type-in screen, the one time you trust that they're going to order it, they don't, and then you wish you would have double-checked. So yeah, I think that's my main thought process in the ED. We get a lot of geriatric trauma too, so it's kind of like really important to find out who the decision maker is, whether it's the patient or a patient family member, because you want to kind of talk them through the surgical options and tell them what the surgery is and see what their functional status is, what they will, ambulate with, walker, cane, so on and so forth. All important questions.
Yeah, and would you still put a fascia iliaca block?
I think that's it kind of, in our system, it depends on if the people who do fascia iliaca blocks are working. So a lot of the time the emergency room physicians will say, hey, do you want a FAI block or fascia iliaca block? and we'll say, yeah, that's fine. I think there's been studies to show that people consume less opiates if they get like a block to help with pain. But the ortho teams, ortho residents are commonly not doing the blocks. Do you guys, who usually handles the blocks over in your hospital?
Yeah, like it's usually ED, but it's usually just junior residents that are doing it anyway. So like one rotation I could be working in ortho, and then I'm not allowed to do them. But then the other rotation I'll be in emergency, and then I can do them.
Oh, really?
So,
that's funny.
yeah. It just depends on the politics in the system.
Yep. Any other thoughts or questions? I think, if I remember correctly, I wrote a skeletal traction guide for the website, and it has a list of everything that we have done skeletal traction for. I'll see if I can find it and share it. But I remember thinking when I first started doing ED consults, I was like, okay, well, what do I need to just be jumping to skeletal traction for in general? And so I tried to make a list of common pathologies or fractures where our attendings at least wanted skeletal traction.
And what's the practicality of it? Like, do you do it, or do the nursing staff do it, or how does it work?
For skeletal traction?
Yeah.
Have you done it at your place?
No, I've never done one.
Oh, okay. So none. Usually the residents would do it. So we would either do it under sedation, or you can actually do it just with lidocaine, numbing up the skin, and then periosteum, where you're going to put your pin. So, if you're doing like a lot of procedures, it makes sense to do it under sedation, because then you can just do all the procedures you need to do really quickly, versus like people can only receive so much lidocaine. So if you're having to do an ankle and then a femur and then something else, it doesn't make sense to try to do blocks and lidocaine on all those different areas. So in high energy situations where people are coming in the trauma bay, we commonly ask for like a propofol or propofol ketamine type sedation. And then before you start, you just make sure you have everything set up. And so there's actually on that same guide for skeletal traction, we have a whole list. I put a whole list of things that when I go to do a skeletal traction pin in our hospital, I will send the nurse working in that area a list of supplies that I need, and they can help me track it down and get it to the bedside, which is super helpful. And that's actually a list of stuff I send them that's on the website. And then you just get a like 2mm K-wire, making sure you have a tension bow, which is different from other types of bows. The tension bows make sure that there's tension being pulled on these K-wires, so that when there's weight hung through the rope that's holding onto the wire, it doesn't just bend the wire. How do I know that? Because I tried to use a 2mm K-wire, which is pretty thin, and a non-tension bow, and the wire did not stay straight. So you need the tension bow. Actually, as you tighten it on, it pulls tension through that wire. And you would literally just get your K-wire driver and put it through your distal femur at the level of the top of your superior pole of your patella. Some people say 1 finger breadth above. The main thing is you don't want to go too proximal and you don't want to go too distal. And then you kind of split the difference. After you poke in the skin, you feel anterior, posterior, split the difference to find, to make sure you're kind of going through bone and you're picturing the middle of the femur from A to P. and then you just send it through the other side of the skin, and then you put your tension bow on and hang the weight on a traction bed. And that's kind of all there is to it. There's kind of like a lot of steps along the way, but you have another option for proximal tibia traction. But one thing to be cognizant of is you have to be pretty sure, like 100% sure, that you don't have a multi-leg knee injury. It's very common in femoral shaft or high energy femur fractures to have occult femoral neck fractures and ligamentous knee injuries. So if you don't have your ligaments holding your knee together and you try to pull 20 to 30 pounds of traction through a knee that's not stable, you end up pulling on the neurovascular bundle, and you can cause intimal tearing and nerve damage, and you can claw off a leg if you didn't catch it. I mean, bad things can happen. So you have to be really sure that your knee is stable before you start pulling through it in proximal tibia traction.
If you're sedating someone for a traction pin, do you still inject lidocaine like on the periosteum?
I did for a while in case I had to revise pins. If they like woke up, by the time I got an x-ray, I could just like redo it without them having a lot of pain. But I stopped doing that because as I got more repetitions, I felt more confident, and I was like, yeah, excuse me, this is in the right place. I also started calling x-ray to the room while I was doing it so I could immediately get an x-ray, and I became a little more savvy to being efficient about it so that I wasn't waiting around for x-ray to come. So commonly, no, I won't put lidocaine in after I do the traction pin under sedation. But you would think that it'd be really painful for someone to do an awake traction pin, but if you use your lidocaine wisely and hit your targets, meaning where you inject lidocaine is where you put your pin, then the pain is reasonable. So you can get it done in a hurry if someone can't tolerate a sedation. Any other questions? Bill, do you have more slides? I forget.
I do. I have just a few more.
Okay.
Just 2 or 3.
Yeah. Let's keep going.
All right. So now here we're on to the 95-degree angled blade plate to fix this subtroch femur fracture. Does anyone want to describe this radiograph in its entirety and say what you're seeing?
Yeah, I'll give it a stab. So you got an AP of the left femur. Looks like the fracture was a subtrochanteric femur fracture. Looks like it did extend to the lesser trochanter. And then fixation is with the blade plate. Alignment looks pretty good. It doesn't look like it's in too much varus or valgus.
Yeah, I think you hit the main points. And so, as Drew was saying earlier, these are not as commonly used as the intramedullary nails, and that's why. That's one of the potential complications, is they can just break. Obviously, there are other complications that can occur, but this one of the theories on this particular case is that cerclage wire also cut off the some of the vascular supply and weakened the bone stock as well. And then, an actual fall of some sort caused the implant to snap.
Yep. Hardware failure with multiple broken screws. And this is an example of like failing into varus. So there's a pretty good, I tried to write about it more in one of our x-ray reading guides, but what does varus and valgus mean? Varus means the distal portion of what you're describing is pointing towards midline, and valgus means the more distal portion is pointing away from midline. So even with a hip, if you picture your angle between your femoral head and shaft, with a varus failure or varus hip, your angle is going to be more acute, and your distal portion is going to be pointing more towards midline. So that's one way to describe it. This is kind of a unique construct. It looks like a almost similar to a sliding hip screw, but it's not something that I think is a newer implant. I don't recognize it, so not that I know all the implants, but a number of these are coming out of textbooks that I think. What is your reference? 2007 on this?
It might be.
I definitely don't have as much experience as some of our faculty, so maybe they'd look at this and be like, "Oh yeah, that's a blank blank from so and so company," but I've not seen this.
Yeah, it's like you're saying, it's probably a much older construct. But the cerclage wire in combination with that lateral plate, it damaged the vascularity, caused the non-union, and ultimately caused hardware failure, significant hardware failure. And then really my last slide is just the key conclusions. So what I want you guys to take away from this is that subtrochanteric femur fractures are, one, they're relatively common, they're complicated, and they require surgical intervention to reduce the non-union and malunion rates when you're treating them. And then intramedullary locked nails are the gold standard for fixation. That's what you should be using in the vast majority of the cases, unless there's a reason not to.
Yep.
And they work well. And then any last questions? Thank you all for coming and listening. I appreciate it.
Nice job, Bill. Thanks for doing this. So if someone asks you, do you want to put a long or short femoral nail in a subtroch, what's the answer?
Long every time.
Yeah, long every time.
Because it increases the stability of the construct and reduces fracture risk and going forward.
Maybe there's people pushing the limits on that, but at least in the Synthes design, the intermediate and short femoral nails can toggle. And also just based on how distal, remember it's 5 centimeters distal to the lesser troch is your subtrochanteric region. That's another stat to remember. That's a very common question. And you need enough stability and overlap to where that fracture has a good environment to start healing. So, long nail.
Exactly. Are there any other questions that we can talk about?
Cool, guys.